This topic is the basics of LV systolic function, remodeling, and left ventricular hypertrophy. I'm Jerry Origema from the Division of Cardiovascular Medicine, Department of Medicine at UMass in beautiful downtown Worcester, Massachusetts. For many years, I thought of systolic and diastolic function as two separate activities. I don't think that way anymore. I think of this as one continuous activity. And what I'm trying to illustrate here is this is a nice 4-chamber cardiac MRI, that there are multiple coordinated activities going on during ventricular systole and ventricular diastole. And I think I was fixated for many years on just the systolic motion where the walls come together and generate the stroke volume. Because of advances in imaging, notably cardiac MRI, tissue Doppler, strain imaging, we know that what is really happening is a three-dimensional activity. And I use this video here to kind of illustrate what's going on. The ventricle twists in systole, just like you wring a towel out, and then it untwists in diastole. The twisting motion stores energy, and the untwisting releases that energy. The twisting generates the stroke volume. The untwisting allows for diastolic suction. So in fact, we are not dealing with separate systolic and diastolic motions, but one continuous motion that really feeds on each other. And because of advances in imaging, we now can quantitate a number of these activities. Let's go back to real basics. This is one of the most famous myocytes in the history of myocytes. I call it the Brad Pitt of myocytes. And pretty much every echo lecture or MRI lecture that you see on systolic function, sooner or later will show you this myocyte contracting and expanding. We understand that fiber architecture in the left ventricle is pretty complicated. And in fact, muscle bundles are arranged in a very complicated weave. So if you took a chunk of myocardium out of the left ventricle and examined the epicardial layer, you would find that the myocardial fibers are running north-south from the base to the apex. And this is also true on the endocardial surface. But in the mid-ventricle, because of this complicated weave spiral architecture, the myocardial fibers are actually arranged in a circumferential manner. So what this means is that a small amount of contraction of this myocyte, say 12%, can result in the ejection of about 65% of the left ventricular end diastolic volume. So the ejection of 65% of the end diastolic volume means the ejection fraction is 65%. And it is because of this complicated three-dimensional weave that a small amount of activity on the part of muscle fibers can generate a majority of the blood being ejected from the ventricle during ventricular systole. And we, as I mentioned earlier, we can actually measure a number of these components of ventricular function. So the way I think about ventricular function is the purpose of the left ventricle is to generate stroke volume. And because of the way the fibers are, the muscle fibers are arrayed in the ventricle, those mid-wall fibers that are arranged in a circular or circumferential manner, when they contract, the radius of the ventricle constricts by about 35% or so. We used to call that fractional shortening The pediatric cardiologists still refer to the fractional shortening. And then what we've paid attention to more recently is this long axis shortening. So the apex of the ventricle remains relatively fixed and the base moves down toward the apex of the ventricle. So the length of the ventricle contracts by about 20%. This contributes to wall thickening because the same amount of mass of the ventricle is present in diastole and systole. So the walls thicken and blood is ejected out the aorta, generating the stroke volume. In turn, these activities are all influenced by preload, which is the amount that the fibers are stretched before contraction, by afterload, which is the load that the ventricle faces in systole, which is made up of the blood pressure and the size of the heart, and by the intrinsic contractile state of the ventricle. If you give digoxin or calcium, you will augment the contractile state. So at any given volume, more of a stroke volume will be generated. These are the basics of systolic function. How do we assess systolic function? Well, by and large, we do this with the ejection fraction of the left ventricle, and we can obtain an ejection fraction through multiple different techniques. And in general, the ejection fractions, from whether you're using cardiac MRI, you're using radionuclide techniques, or echocardiography, the ejection fractions are roughly the same on an individual person. And in fact, the ejection fraction normal range doesn't vary that much as you go from childhood to adulthood. And for this reason, the ejection fraction has stood the test of time. There are lots of outcome data that support the fact that a normal ejection fraction generally gives you a good prognosis. As I implied, it's an easy index to compare between different modalities. And importantly, it's internally normalized. What do I mean by that? Well, if the ejection fraction is the stroke volume divided by the end diastolic volume, as someone gets older or gets bigger, or we're dealing with small people versus big people, both the end diastolic and the end systolic volume will increase proportionally. So the ejection fraction is the percent of the ventricular volume that is being ejected. That's not going to vary much between individuals of different sizes because both the diastolic and the systolic volumes are scaled up. As I went over in the chamber quantitation lecture, the preferred method is Simpson's biplane method of discs. The stroke volume is the difference between the end diastolic and the end systolic volume, and the end diastolic volume, the stroke volume rather, divided by the end diastolic volume gives you the ejection fraction. You can think of this as the change in end diastolic volume during systole, or the volume strain, and we'll talk about that later. So the ejection fraction, in this case, 46%. We have parameters for what a normal ejection fraction is, and for men, it's a little bit lower. The lower end of normal is a little bit lower than for women. So anything above 52% gets you into the normal range for men, and anything above 54%, at or above 54%, gets you into the normal range for women. Many clinical trials have used an ejection fraction of 50% to define the difference between heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. So keep in mind that the numbers are a little bit different than the echocardiography guidelines. But for the purpose of the examination, you should be thinking in terms of 52 and 54. Now, these numbers changed a little bit between the 2005 and 2015 chamber quantitation guidelines. Now, we've been saying a lot of good things about the ejection fraction. There are some limitations that you need to keep in mind, and I've listed these on this slide here. The ejection fraction is influenced by load, and we talked about preload and diastolic fiber stretch, how much the fibers are being stretched before the next contraction. Just think of a spring. The more you stretch a spring before releasing it, the more forceful the spring will spring back. That's, in a sense, preload. Pump function, meaning what the ventricle is actually generating in terms of stroke volume. And as you'll see, you can have superb ejection fraction, but if your chamber is small for the size of the body, your pump function may not be normal. And finally, you can have a normal ejection fraction with abnormalities in regional function, meaning, as you know, you can have an inferior wall motion abnormality due to right coronary disease, but a preserved ejection fraction because other parts of the ventricle may become hyperdynamic to keep the stroke volume normal. Afterload, as we implied, is related to the size of the heart and the pressure it must generate during ventricular systole. Afterload is inversely proportional to the thickness of the wall. So, a couple of points to keep in mind here. Afterload is not simply pressure. For example, in the case of aortic regurgitation, chronic aortic regurgitation, systolic blood pressure may be reasonably normal, but the afterload on that ventricle may be significantly elevated because of the volume component of this Laplace relationship. So too, patients with severe hypertension, if they have developed compensatory hypertrophy, so in the Laplace relationship here, wall stress or afterload directly proportional to systolic pressure, directly proportional to the radius of the ventricle, but inversely proportional to wall thickness. One can have a situation, and you see this all the time with aortic stenosis, where the systolic pressure that that ventricle is generating is very high, but because of compensatory hypertrophy, this wall thickness tends to spread out the load and keep the wall stress in the relatively normal range. It will be elevated, but it's attenuated by the increase in wall thickness. So remember this Laplace relationship, not necessarily for the examination, but for clinical practice to help explain how it is that a ventricle in somebody with severe untreated hypertension can still have a normal ejection fraction despite an impressive increase in systolic pressure. The heart remodels to normalize the load per unit myocardium. Now, when we talk about remodeling of the ventricle, some of it is in accordance with the Laplace relationship, but hearts that are subjected to pressure load, like in aortic stenosis, hypertension, and to a certain extent HCM, will have very different looks to them compared to volume-loaded ventricles, such as are seen in aortic regurg, mitral regurgitation, dilated cardiomyopathy. So if we consider the normal ventricle has a normal ejection fraction, hypertrophy, which is mass, left ventricular mass, indexed to body surface area, if that value is normal or is normal, then hypertrophy is said to be absent. And the geometry, which is more or less the ratio of the thickness of the myocardium to the size of the chamber, is normal. This person is normal. So let's take pressure overload and let's take this hypertensive heart here, for example. Ejection fraction is normal, as you can see. Hypertrophy is present. Now you have to take my word for it. This wall thickness is so much greater than normal that when we end up calculating the left ventricular mass, we'll see this later in the lecture, and index it to the size of the person, left ventricular mass index is elevated. So hypertrophy is said to be present, but the pattern we call concentric, because the ratio of thickness to the size of the ventricular cavity is increased. And we'll talk about the partition values in a second. So this ventricle is adapted, its piston shape is adapted to pressure, generating stroke volume at high pressure. Conversely, this ventricle, which has a very large volume and a large ratio, a diminished ratio of thickness to ventricular cavity, is known as eccentric hypertrophy, and this is seen in volume load situations. The spherical shape of the ventricle is adapted to generating large stroke volumes, as might be expected in these conditions. So left ventricular remodeling, we know when subjected to pressure load, the myocytes thickened, and you have this concentric pattern. Myocytes tend to lengthen as opposed to thicken in volume load. Interestingly, the length of the myocytes the sarcomere length stays roughly the same, but the ventricle remodels to line these up in series as opposed to lining these up in parallel. Let's talk about aortic stenosis. This is the prototype afterload excess lesion. Now, you can see that this ventricle has a reduced ejection fraction, but if you actually examine the myocytes, if you can extract them and examine their function, you might find that the myocytes under normal loading conditions the function might actually be normal. So I kind of say this tongue in cheek, no bad myocytes, only bad loading conditions. And you always have to keep in mind the loading conditions, particularly in valvular heart disease, before you say that there is intrinsic abnormality in muscle function. So perfectly normal muscle under very adverse loading conditions where the amount of remodeling of the ventricle and compensatory hypertrophy may cease to be adequate for the amount of load can result in a reduced ejection fraction. And this relationship is shown here. If you compute the ejection fraction and the systolic load, and just for sake of argument, just assume that this systolic load here given by the sigma is the direct product of pressure and the size of the heart and inversely proportional to wall thickness, you see that the relationship between ejection fraction and load is inverse. This is from a study of patients with aortic stenosis. So it's possible that you can have a reduced ejection fraction, and we're not talking about reduced ejection fraction due to myocardial infarction or coronary heart disease, but in pure aortic stenosis, a reduced ejection fraction does not necessarily mean that contractile dysfunction is reduced. It can be simply due to the load. And if you reduce the load by aortic valve replacement, the ejection fraction can and will improve. And I've got a couple of examples of this here. These are old echoes. This is before and after aortic valve replacement for severe aortic stenosis. Notice how the ventricle shrinks down and the ejection fraction improves. Not quite normal, but in time probably will become normal. Here's a little bit more of a dramatic example in a newborn with congenital aortic stenosis. This is pre and this is post balloon valvuloplasty. Reducing the load improves the ejection fraction. If the reduced ejection fraction is due to the abnormal loading conditions. And we see this in clinical practice. So sometimes ventricles that look like this coming in patients with untreated hypertension can look like this after the blood pressure is treated. And I have a whole collection of these reversible LV dysfunction cases, and many of them are due to undertreated or untreated hypertension. So to summarize, different types of adaptation to different loading conditions. One of the characteristics of volume-loaded lesions, such as aortic regurgitation, is the ventricle becomes more spherical. And we have a parameter known as the sphericity index, which you will likely not be tested on, but just keep in mind that volume-loaded hearts become more spherical, as we've mentioned. Couple of points about the sphericity index. It's basically a ratio of the short to the long axis. A spherical ventricle is at a mechanical disadvantage. And in clinical practice, aortic regurgitation, dilated cardiomyopathies are where you will see this. Now, I just want to make one small point. The purpose of dilation, or the benefit of dilation, I should say, is to allow the ventricle to generate a normal stroke volume despite reduced contractile properties of the LV. So if this is normal, stroke volume is 81, notice that if your ejection fraction is reduced and you've had time to remodel so that the LV enlarges, you can maintain a normal stroke volume at rest. Conversely, a good ejection fraction with a tiny ventricle, if it will generate a small stroke volume. So 85% of a ventricle whose volume can be contained in a thimble will give you a small stroke volume. Now, we've paid a lot of attention recently, and you'll get a whole lecture on this by Steve Lester. We've paying a lot more attention to the longitudinal function of the left ventricle. And I would keep in mind what the waves of tissue Doppler, which measures the velocity of myocardial movement, what these look like. So during ventricular systole, you have isovolumic signal, kind of an up and down signal, as you see here. This is the systolic phase of the tissue of ventricular systole. Excuse me. This is the ejection phase of systole and what it looks like on tissue Doppler. Then you have a down and up signal that comprises isovolumic relaxation, and then an early and a late velocity movement of the annulus. So just keep these in mind, this general morphology of tissue Doppler. The first up and down signal are isovolumic contraction. The last up and down are isovolumic relaxation. I just show this slide just to illustrate that the lateral tissue Doppler velocities in diastole are higher than the septal tissue Doppler velocities in normal individuals. And there is an age dependence of this over time. You need to know this to understand what the so-called TE index, or the index of myocardial performance, which is actually pretty ingenious. And the way I think of the TE index is the amount of time that is spent generating pressure and relieving pressure per unit stroke volume. So an infinitely normal or infinitely strong ventricle would basically be able to generate a stroke volume with minimal isovolumic contraction and relaxation periods. A very weak ventricle would spend a long time in isovolumic contraction, generating pressure and a long time relieving pressure in isovolumic relaxation, and would have a relatively short ejection time because the stroke volume is not very large. So if you add up the isovolumic contraction time and the isovolumic relaxation time and divide it by the time spent ejecting blood, and as I mentioned in another lecture, the ejection time is a good surrogate for stroke volume, you have the T index, the index of myocardial performance. So normal values for the left ventricle will be roughly 0.4 or so. So again, an infinitely strong ventricle will have a large ejection time because of a large stroke volume and will not take much time generating pressure or for pressure decay. So the T index will be relatively high. A weak ventricle will have a low stroke volume and therefore a low ejection time and very long isovolumic times. There's another method that is an indirect method of assessing left ventricular function, and that is the rate of rise of pressure in the left ventricle utilizing the continuous wave envelope of mitral regurgitation. So if you have a mitral regurgitation continuous wave signal, you can select 2 points at 1 meter per second and 3 meters per second on this curve. And many of the software packages will allow you to do this. So if you know how long it takes to get from 1 to 3 milliseconds, measure that time. That gives you the change in pressure. So 36 minus 34 or 32 millimeters of mercury divided by the time, you will have an index of systolic function. And in this example here, the maximum dPdt was 401. 55 milliseconds was the time between 1 and 3 meter per second. And this translated into a dPdt of 400. Now, you can get the same information just by looking at the envelope. And in another lecture, I mentioned that triangular shapes on CW, particularly in systole, are usually bad news bears. So if you see a triangular shape, it's telling you that the ventricle is generating pressure very slowly. And here's another example. So here's a patient with mitral regurgitation, and we take measurements at 1 and 3 meters per second. We measure the time between the two, and that time was 71 milliseconds. We divide 71 milliseconds into 32 millimeters of mercury and come up with 452 millimeters of mercury per second. And as you can see, this envelope is very gradual. Contrast that to this case here. This was a patient I took care of with acute severe mitral regurgitation due to bacterial endocarditis. Look at how rapid this dPdt is. And you can see the left ventricle is banging away. It's a totally afterload, low afterload situation. Let's spend the next few minutes talking about regional function. You really do have to know a few things about regional function for the board examination. So, as you can see on this slide, regional wall motion abnormalities at rest may not be seen until the luminal diameter stenosis exceeds 85%. With exercise, you don't need quite as much to create a regional wall motion abnormality. Now, echocardiography can overestimate the amount of regional of ischemic or infarcted myocardium because of tethering, because of disturbance in regional loading conditions, and because of myocardial stunning. Wall thickening really is a superior index of systolic function than is endocardial motion. And as you know, regional wall motion abnormalities can occur in the absence of coronary artery disease. Just think about non-ischemic cardiomyopathy or left bundle branch block. Now, a wise person, me, pointed out that a normal overall ejection fraction may belie important regional dysfunction, and that is certainly the case with coronary artery disease. The echo is often our first tool in deciding on whether someone has acute coronary disease. Regional wall motion abnormality can occur within minutes of a coronary ligation in experimental animals. The rate and amplitude of the endocardial excursion is decreased, and you may see reduced wall thickening. It's very important that you know the coronary artery territories. So if you had to memorize one thing, if you don't already know it, it is where, first of all, what the segments of the left ventricle are. This is in the quantitation guidelines of 2015, and how they map with coronary territories. And I'm not going to go through this with you, but you have to know this. The last time I took the board examination, there were multiple questions on wall motion abnormality and which coronary artery was involved. We'll see a couple of examples of this in a second. This is a diagram that I made that helps me teach the fellows which walls you're actually looking at. The plane of the four-chamber view generally goes through the largest aspect of the right ventricle and the left ventricle and is in the mid portion of the left ventricle. The three-chamber is about 60 degrees away from that, so it's looking through the aortic outflow tract, and the two-chamber through the free wall, anterior free wall, left anterior descending artery sits here, and the posterior descending artery sits there. So three-chamber, four-chamber, two-chamber. In the two-chamber, the back wall is supplied by the RCA, given here in blue. It is sitting next door to circumflex territory, which is here, which is given, which is seen in this inferolateral wall here. This area here, the free wall, is supplied by the left anterior descending artery. Now keep in mind there can be overlap. Sometimes the right coronary artery can supply part of this circumflex territory. Sometimes diagonal branches can supply this area here. But in general, RCA territory, LAD territory, circumflex territory here, recognizing that there can be overlap. Let's take a look at this echocardiogram, 25-year-old man with chest pain, and let's look at the wall motion. I would tell you that the wall motion abnormalities you'll be asked to decipher for the board examination will be reasonably straightforward. This is a clear-cut case of a problem with the apex of the left ventricle on this two-chamber view. Anterior wall is not thickening, and apex is down. Anteroseptal wall here, the lung axis, is down. This is an LAD territory occlusion. And this is the angiogram that shows a flush occlusion of the left anterior descending artery before it was reperfused. How about this one? Again, what I'm pointing out here is that the inferior wall is not contracting here. And from this diagram here, this is right coronary artery territory. And when we talked about tethering, and this is a known RCA occlusion, by the way, notice that this inferolateral wall here is not thickening normally. And in all likelihood, it is because it is tethered to dysfunctional or infarcted myocardium in the RCA distribution. And that's why it's not thickening quite normally. Remember, the area of wall motion abnormality will overestimate the histological amount of necrosis. And tethering is one of those reasons. If your segment is tied to an area that is not contracting, its excursion will not be normal. Now, understanding the relationship between the planes can clear up a couple of problems. Now, for years, I was mystified by the fact that different four-chamber views told me a different story about regional wall motion abnormality. Here's a case where there is basal inferior wall motion abnormality, but on this four-chamber view, same patient, later on in the study, the wall motion abnormality doesn't seem quite as pronounced. How is that? Did the person go from ischemic to not ischemic? No, it's a matter of image plane. Now, we don't have complete control when we're doing a two-dimensional echo of where our transducer is. We don't know exactly where the transducer is. One little hint is if you see the coronary sinus on your four-chamber view, then you're probably pretty far down in the ventricle, more toward the posterior wall and the crux of the heart. So what I'm telling you is that this second image was probably obtained at a slightly higher plane, more in the anterior wall than the anterior portion of the septum with some LAD perfusion than in the inferior portion of the septum, which is more pure RCA territory. And I think with the advent of three-dimensional echo, as this becomes more disseminated, we'll understand these things a bit better. I think I'm going to skip over this just in the interest of time and move on. I want to point out that not all abnormal wall motion is due to coronary artery disease. So excuse me, here, let's see, we play these. Yeah, which person has the acute infarct? Well, the answer is it's patient A. This is a case of left bundle branch block, and this is a case of pseudo dyskinesis. Let's spend a minute talking about left bundle branch block. This is a person with a left bundle branch block, and I'm asking you what the diagnosis is. Is it LAD territory infarction, LAD ischemia, volume loaded LV, or none of the above? The answer is this is a pure left bundle branch block. No coronary disease, no volume load from a valvular regurgitation. And you see that these walls are basically at war with one another. When the lateral wall comes in, the septal wall bulges out. This is characteristic of left bundle branch block. Why is this? And we call this the violent left bundle branch block at UMass. Jeff Hill, our sonographer extraordinaire, used that phrase when he was with us, and it's kind of stuck. Well, from tissue Doppler, or from strain imaging rather, we know that the peak strain of the lateral wall occurs and is robust. No, I'm sorry, let me start this again. The lateral wall expands early in systole because when the septum contracts, it preloads the lateral wall. And so when the lateral wall finally contracts later in systole, it produces a very robust outward motion of the septal wall. So in fact, as I said earlier, the walls are at war with each other. When the septum depolarizes, since it gets the electrical signal first, it expands the lateral wall. It preloads the lateral wall because the lateral wall is still in diastole. And then when the lateral wall comes in, its strain or longitudinal strain is enhanced, and it has the effect of blowing the septum out of the picture. So here are a couple of other examples of left bundle branch block before and after CRT. This one was given to me by Rick Grimm many years ago, and I think to date is one of the best examples of left bundle branch block before and after CRT. Contrast is useful because of lateral wall dropout, and we recommend in evaluating left ventricular systolic function, if you have more than two contiguous segments, or poorly defined, use contrast, and it can certainly help with detecting regional wall motion abnormalities.
I'd like to switch gears, as they say, and talk in the last few minutes about the quantitation of left ventricular mass. By the way, if you ever find yourself in Munich, I would heartily recommend a visit to the BMW Museum. Now, we've talked about left ventricular hypertrophy, and I mentioned earlier that the definition of left ventricular hypertrophy was an increase, an abnormal increase in the amount of left ventricular mass indexed to body surface area. Many people use the term hypertrophy a little bit more loosely than that. And in my own career, there are times where I would write hypertrophy down on the echo report form if the wall thickness was abnormally
Increased, or the relative wall thickness, meaning the ratio of the wall thickness to the left ventricular cavity dimension, seemed abnormally high. But I think it is important for us to use the term the same way. And I would urge you to confine the term left ventricular hypertrophy to those patients who have an abnormal increase in left ventricular mass index, or index to body surface area. So we'll talk for a second about how we arrive at left ventricular mass measurement. Here is an echocardiogram for somebody from somebody with longstanding hypertension. Resistant hypertension, also has diabetes. We have a body surface area of 2. So let's zero in on this terminology. The entire universe of patients can be subdivided into one of 4 categories based on whether their left ventricular mass index is above a certain partition value, which is the mean plus 2 standard deviations of what is obtained by pooling a good deal of data obtained in many parts of the world. So let's assume for a second that we have a method that will give us the left ventricular mass, and we'll talk about that, and that we've established partition values for abnormal increase in left ventricular mass index, and those numbers are 115 grams per meter squared, greater than 115 grams per meter squared for men, and greater than 95 grams per meter squared for women. So on the right side of this grid, left ventricular mass is abnormally increased. We use the term hypertrophy to designate this. If at the same time we take twice the posterior wall thickness and divide that by the left ventricular diastolic dimension, we can subdivide the hypertrophy and the non-hypertrophy group into those who have an increase in the relative wall thickness, meaning a high ratio of wall thickness to cavity dimension, versus those who have a normal ratio. And the partition value that is used in the guidelines is 0.42. These numbers are probably important for you to commit to memory. So if you go into a hypertension clinic, you will find that, first of all, about 25% of patients in the clinic with hypertension will have left ventricular hypertrophy. A much greater percentage by echocardiography than by electrocardiography. You won't be tested on that, but this is good to know. And that the population will be also have a fair number of patients with concentric hypertrophy, a thick-walled ventricle. Fewer people will have eccentric hypertrophy, and there'll be a good chunk of people who have concentric remodeling. These are individuals who have an abnormal increase in their relative wall thickness, but their left ventricular mass index is normal. Who are these people? Well, whether these are people who are on their way to developing frank hypertrophy but haven't gotten there yet, I don't think we completely understand who the concentric remodeling patients are. Uh, some have argued that if you use body surface area as opposed to, say, height to index your left ventricular mass value, you will classify patients as having normal left ventricular mass index who are obese. And some have argued that height or other metrics, height raised to some exponent, might be a preferred method because it does not allow obese people to skate in terms of the designation of left ventricular hypertrophy. I'm going to sidestep those arguments and just say that probably we are counting using this method of indexation. There probably is a small percentage of patients who have obesity-related hypertrophy, but because we're dividing by the body surface area and that's elevated in obesity, they get classified as concentric remodeling. So how do we actually compute the left ventricular mass? Well, let's assume we have these dimensions here. We compute the relative wall thickness as stated above. That is twice the ratio of the posterior wall thickness to the left ventricular internal diameter. That comes out to be 0.64, solidly in the concentric range. Remember, the partition value is greater than 0.42. How do we get the left ventricular mass? Well, I'm going to take you on a little sentimental journey. I don't think you will be tested on this, but you may be curious as to how we actually derive a left ventricular mass from linear dimensions provided by echocardiography. So if we assume that the left ventricle is shaped like a football, and this is known as a prolate ellipsoid of revolution, and we make some other assumptions, namely that this axis, this minor axis of the football or this shape is equal to that axis. And this is true for footballs generally outside of New England when Tom Brady was quarterback. They generally had this prolate ellipsoid shape. And then you further assume that the length of the left ventricle is twice either of your minor axis dimensions, because they're both the same. You can make some substitutions into the formula for the volume of a prolate ellipsoid and basically come out with left ventricular volume is the left ventricular internal diameter cubed. And I mentioned this in the chamber quantitation lecture that a quick and dirty way of arriving at a left ventricular volume from a single linear dimension was to cube the linear dimension, assuming that the shape of the heart was that of a prolate ellipsoid. So how do we get left ventricular mass out of this? Well, we can assume that there are two prolate ellipsoids representing the left ventricle, an inner ellipsoid, which is the left ventricular cavity, and an outer ellipsoid representing the cavity plus the wall thickness on either side. So if we assume that the volume of this outer shell is given by 5 plus 1 cubed, and the volume of the inner shell is 5 cubed, the shell volume, the volume of this gray stuff in between the left ventricular cavity and the outer wall, is 118 ml. That is 343 minus 125. But we can't stop there because the specific gravity of the heart muscle is greater than 1. In fact, it is 1.04 grams per ml. So one arrives at a volume, a mass, converting a mass volume to a mass using the specific gravity. The mass is actually 122 grams. Then you have to go ahead and index that by the body surface area to get your left ventricular mass index. So basically, this is the principle behind measurement of the left ventricular mass index. And interestingly, for pretty much all the epidemiologic echo studies that have been done, Framingham, Cornell, the Flamenco study rather, and any number of studies have relied on this formula to compute left ventricular mass index, and it is embedded in our literature. And we know, for example, that an abnormal left ventricular mass index is an extremely strong predictor of poor outcomes in all manner of heart disease. And I've heard Dr. Devereaux, who has done more work than just about anybody in the field of hypertensive heart disease, say that beside age, left ventricular mass index is the single most potent predictor of outcome compared with any other variable. So this is how we arrive at left ventricular mass index and relative wall thickness. Some partition values that have been given in the guidelines, as I mentioned, are shown here in the table. There are also values for wall thicknesses. Two-dimensional echocardiography and even 3D echocardiography have been used to compute left ventricular mass index, but these are seldom used. So if you were to memorize any values, I would memorize the partition values for men and women. Relative wall thickness partition values are the same for men and women. One reason why this is important is because left ventricular increase in left ventricular mass index, or even concentric remodeling, as we've talked about, that is an increase in relative wall thickness with a normal left ventricular mass index. These entities are really overrepresented among patients with HFpEF. And seem to predispose patients for heart failure with a preserved ejection fraction. We've known this for a long time, that left ventricular mass index is a potent predictor of the heart failure outcome, added to which I would mention that it had long been thought that the pattern of hypertrophy seen in obesity is the eccentric hypertrophy pattern. Well, we know now through a number of studies in obesity that it's actually concentric geometry, either concentric remodeling or concentric hypertrophy is what is the most common form of altered left ventricular geometry in obesity. Of course, obesity coexists with obstructive sleep apnea and hypertension. And so these factors alone or together promote abnormal left ventricular remodeling.